this will be. So to start with, we will go over the neurologic exam just briefly, talking about some of the things that are unique to the cat with the neurologic exam, and then discuss the unique diseases that are listed. Diseases that are similar to dogs we will not go through. For example, this is a radiograph of a cat here on the right. And if you look at the radiograph, you can actually diagnose what is wrong with this cat. So if you want to pause it and look for a minute, and then I'll put up the MRI. So if you saw the radio-opaque lesion between L5 and L6, then you might have presumed that there was an intervertebral disc herniation, which is correct. So don't forget that although cats have their unique diseases that they can still get the same diseases that dogs can get as well. Briefly, just on the examination, some things that are special to the cat. When you're looking at CPs, the conscious proprioception or the knuckling test, sometimes it's not as reliable as it is in the dog. And I often find that hopping, extensor postural thrust, and wheelbarrowing are more reliable. And in this cat, it's a good example to where the CP looked pretty normal, but you can see the hopping to the right is pretty delayed. And that's true in the pelvic limbs as well. One final note that I'll make is when you're doing the menace on a cat, it's best to be out of the field of view of the cat when you come in to do the menace. So I often stand behind the cat and then bring my hand quickly in front of the cat's face to see if they will menace or not. So again, this is just a good example of how the conscious proprioception is not as reliable in the cat as it is in the dog. far as talking about some of the diseases now, so the first disease we'll talk about is feline hyperesthesia syndrome. This disease is not well understood, but this video does give you a good example of what it will look like. So often cats will flick their tail. Sometimes they can be vocal and seem very agitated, and it's not uncommon for them to actually attack themselves towards their back end, as you'll see this cat do. Generally, the episodes are at random, although sometimes it can be related to stressful events. And I've had a couple cats myself that have these events and also fluted as well. But it's not a typical finding to have fluted cats with hyperesthesia syndrome and vice versa. But it just goes back to where I feel that there might be some stress involved for some of the cats in this disease. So with feline hyperesthesia syndrome, they're usually younger, so less than 1 year of age. Um, Again, the exact cause is not known, but if you do a pretty thorough workup, you'll find that everything else should be normal in these cats. There was one paper out of the 90s that discussed the possibility of a vacuolar myopathy, but several papers have looked at the same regions that this one paper had, and they do not find the same thing. So most of us conclude that this is not a vacuolar myopathy. And treatment is generally with gabapentin, to where about 2/3 of patients will respond. It might not completely resolve the episodes, but it does at least improve them and decrease the frequency. Behavior modifying drugs can also be used, so clomipramine and amitriptyline are tricyclic antibiotics that have, tricyclic antidepressants that have had some success. Sometimes antiepileptic medications can also be used. I've had some success, but most patients, if they're going to respond to any sort of medical therapy that I've had luck with, do so with gabapentin. As a last result, you could try anti-inflammatories as well. That's it with feline hyperesthesia syndrome. Next, we'll talk about idiopathic epilepsy in cats. So this can occur at any age in the cat, but similar to dogs, it most commonly occurs in patients under 6 or 7 years of age. In fact, it's extremely rare to happen once cats are over 13 or 14 years of age. When a patient has a seizure, it usually occurs during resting conditions when they're sleeping. And the phenotype of the seizure is different compared to structural disease, as many of these cats will have rapid running seizures, meaning that they literally will run around the house during the seizure episode. So if a cat has a phenotype such as this, and it occurs, and when they have this, if they have the rapid running and they're occurring when they sleep, you can almost guarantee that this is going to be idiopathic epilepsy. Status epilepticus is very uncommon in cats as well, and these cats are uncommon in cats with idiopathic epilepsy, and these cats should be normal during interictal states. As far as treatment for idiopathic epilepsy, the drugs are pretty similar to dogs, except for the potassium bromide. So phenobarbital and levetiracetam are commonly used. And about a third of cats will have some degree of side effect to the medication, but it's usually minimal. And the cats usually don't have that lifelong. After a week or two, the side effects should subside. If you're looking at the kind of a hierarchy-based pyramid for the quality of evidence, the newer anti-epileptic medication, mepitone, appears to be the safest. However, it might not be the most effective, so phenobarbital still seems to be the most effective. Interestingly, in cats with idiopathic epilepsy, levetiracetam seems to be more effective for idiopathic epilepsy than it is in dogs. So the general consensus from the International Epileptic Task Force is that healthy cats with no liver disease should be put on phenobarbital first to control seizures. If they have liver disease, Keppra would likely be the next appropriate choice. Once mepitone is available in the United States, it might be another alternative for either of these medications as well, since levetiracetam has to be given 3 times a day. With idiopathic epilepsy, younger cats usually have a better prognosis than older cats, similar to dogs. As a general rule, about 70% of cats will respond to anti-epileptic drugs. However, about 20% of cats will die, but it's often from different reasons other than just idiopathic epilepsy. Some cats can have behavior changes. Other times it's other diseases that occur as well, especially in older cats. Interesting, in cats, about 40% can actually go into complete remission of the seizures within a year. And this is without any sort of anti-epileptic drugs. So ideally still recommend using anti-epileptic medications in these cats because most will not go into complete remission. However, if you have a cat that cannot be medicated and the seizures are not frequent enough to be interfering with quality of life, it's okay to try to ride that out to see if this is a cat that might go into remission. Again, assuming the quality of life is not severely affected. Another form of seizures that cats get, other than idiopathic epilepsy, is audiogenic reflex seizures. So a reflex seizure is defined as a seizure that is objectively and consistently precipitated by environmental or internal stimuli. So the phenotype for these seizures is usually different than what we would see with idiopathic epilepsy, and it usually starts out with these myoclonic jerks, more of a focal type seizure before it generalizes. And I'll let the video play so you can see the phenotype of this seizure. So as the name implies, audiogenic reflex seizures are usually the result of a certain sound. So this seems to be that Burmans are overrepresented, and on the right of the screen is an example of a Burman. These are usually older cats, so mean age of 15 years. Again, the idiopathic epileptics are typically younger. The most common sound associated with this has been crinkling of foil, but any sort of high-pitched noise can cause this as well. Tapping of a glass, a metal spoon falling, etc. So the treatment of choice would be to avoid the noise, as it eliminates the majority of seizures in these cats, which makes sense. And this is actually a condition where Keppra seems to be much more effective than phenobarbital, with about 93% response for the myoclonic seizures, 70% response for the tonic-clonic seizures, whereas phenobarbital only had about a 27% response rate. Now there's another type of or phenotype of seizures that cats can get as well. It's a focal type of seizure, usually associated with significant hypersalivation. And like other focal seizures, this can eventually generalize, but it doesn't have to. So if you have a cat with this kind of presentation where they're having focal seizures with hypersalivation,
It's okay, Mama.
the thing I'd be most worried about is a condition called hippocampal necrosis. And so these are MRI images, and on the left is a T2 weighted sequence, and on the right is a T1 post-contrast sequence. And what's highlighting on that contrast on the right is going to be the hippocampus that has complete contrast uptake. And if you look where that region of the hippocampus is that has the contrast enhancement, there's also a hyperintensity on T2 as well. And this is due to necrosis of the hippocampus. So the exact cause of hippocampal necrosis is debatable. About 50% of cats that have been investigated, there is a potassium channel antibody that is present. So there is some thought, at least in a fair percentage of cats, that this is actually an immune-mediated condition. And people suffer from the same problem, where there's also antibodies towards a specific potassium channel within the hippocampus. So these patients need antiepileptic therapy. They can often be resistant and need multiple drugs, but typically we'll start with phenobarbital in these patients. Because of the chance of this being an immune-mediated disease, we usually will add in immunosuppressive prednisone as well. But there's no evidence to truly say that these patients will have a better prognosis if prednisone is or is not used. Unfortunately, in my experience, most of these cats do not do well with or without prednisone therapy. But I've had a couple that live for at least a year, but unfortunately I do lose them to follow-up. But most of the time, after a month or so, things still progress and owners elect euthanasia. So now we'll move on to CNS infectious diseases in the cat. This is just a complete list for you, but we're only going to focus on some of the more common infectious diseases. So the most common cause of CNS disease in the cat is going to be FIP. And the most common infection that causes CNS disease is also FIP in the cat. So in as many as 10% of cats infected with feline coronavirus, host and viral interaction allow the virus to replicate within the macrophage, ultimately resulting in systemic disease manifesting as immune-mediated vasculitis. And again, this is the most common CNS disease in the cat. So it's not necessarily the virus that's causing the issue, it's the host and virus interaction that ultimately leads to the disease. And things that can clue you into FIP are listed here in blue. So I'll let you can pause this and read this, and I won't read that to you. As far as things that also might clue you in, things that also might clue you in that this is feline infectious peritonitis is you can have anterior chamber hemorrhage and inflammation with marked vasculitis, as you can see on the left, and on the right is a good example of perivascular cuffing. It can be hard to truly diagnose FIP. There is CSF that you can send out for PCR. It only looks for the coronavirus, but coronavirus should not be within CNS. So if you have clinical signs consistent with FIP and PCR positive CSF, it's pretty diagnostic for the disease. MRI changes are fairly pathognomonic as well, to where you get this ventricular dilation from increased hydrostatic pressure. There's usually periventricular hyperintensity, and on the top right of the screen is a T1 post-contrast. And you can see that there's periventricular contrast enhancement from the significant vasculitis that's occurring. Unfortunately, FIP is fatal. You can try immunosuppressive dosages of steroids because, again, it's that interaction between the immune system and the virus that's causing the issue. And some people say feeding a very high protein diet gives you a better chance of surviving as well in these cats. But most of the time, by far and away, it's going to be fatal. There is a newer antiviral medication that is being used at UC Davis that does show promise, where about 80% of cats will go into remission. I have tried getting this drug in the past, but have had a lot of difficulty. So I think until the study's complete at UC Davis that proves the efficacy and safety of this drug, we're still going to be left with trying steroids in these patients or euthanasia. So the second most common CNS disease is going to be, or infectious CNS disease is going to be toxoplasmosis. So cats are the definitive host for Toxoplasmosis gondii, which is an intracellular coccidian parasite. Infection is usually the result of ingestion of prey harboring bradyzoites, but feces containing oocysts are another potential source of infection. Toxoplasmosis is typically a multisystemic disease, which may either be acute or chronic. Acute disseminated disease arises due to rapid replication of the tachyzoites, often within the liver, the CNS, pancreas, or lungs. Chronic disease is more typically associated with vague signs such as fever, anorexia, weight loss, and diarrhea. Dissemination of chronic disease may occur if patients become immunosuppressed, such as if they're receiving cyclosporine, or if they had some sort of viral infection, or if they're receiving chemotherapy. CNS disease is most commonly seen following reactivation of latent bradyzoites within the brain, spinal cord, or the skeletal muscle. This often manifests as neurologic and ocular signs. And then there's the absence of systemic disease. So if you have the chronic, or if you have the CNS disease, if it's from a chronic or a latent infection, there's usually not systemic signs present as well. And again, this might be a sequela of immunosuppression, such as with chemotherapy or retrovirus. And so, again, here you can see some of the inflammatory plaques that are present. And then this is an example of anterior uveitis that's present in a cat with toxoplasmosis. Diagnosis can be with serology or PCR, and usually when you send out serology, you're going to get IgG and IgM. So again, CNS disease without other clinical signs. If all that's elevated is an IgM, that would be atypical. So I would expect to see IgG elevated in these patients with CNS disease only. But if there's other signs and you get an elevated IgM, then it makes more sense that it could be related to the toxoplasmosis. Another way for diagnosis is actually biopsy tissue, and you can see the protozoal tissue cyst. Treatment is usually with clindamycin for about a month, and clindamycin is a static type of medication for protozoal disease, so it's not really cidal, whereas trimethoprim sulfa is, but there are more side effects associated with trimethoprim sulfa. Both have decent CNS penetration, with trimethoprim sulfa having better CNS penetration. So if you have a patient with toxoplasmosis that's not responding the way we would expect to treatment, you could switch them to trimethoprim sulfa from clindamycin, but we usually start with clindamycin. You can also give a couple days of prednisone as well at an anti-inflammatory dose, just to prevent a severe inflammatory reaction from occurring from a die-off of the tissue cyst. Another infection is cryptococcus. Cryptococcal infections are attributed primarily to Cryptococcus neoformans, although the Gadi may be involved in some cases. These saprophytic yeasts are typically found in soil and pigeon feces, and infection is thought to be by inhalation. In people, the infection appears to spread from the lungs to the CNS by hematogenous route. While spread via this tissue may also occur in cats, neurologic involvement more typically arises as a result of extension from rhinitis. Although Cryptococcus is the most common mycotic infection in cats, it is still a rare cause of CNS disease, accounting for only about 1% of cases. Clinical signs associated with cryptococcal infection are signs of lethargy and behavior changes, with gait abnormalities being the most common. They can get vestibular signs and seizures as well. And it's usually a multifocal or diffuse condition, although focal lesions can occur. Concurrent systemic clinical signs usually include nasal and upper respiratory signs, although lower respiratory signs can also occur. And cutaneous disease can also occur, and if it is present, it's usually affecting the face. For diagnosis, serology to Miravista is probably going to be the easiest way to diagnosis. You can do CSF, although a lot of these patients will have increased intracranial pressure, so it's a little bit scary to do. But you can usually see the organism on CSF, and then fungal culture is the gold standard. Because of the risk of doing fungal cultures, it's usually not performed. So here was a patient who had acute bilateral blindness, and on fundic exam you can see this granulomatous chorioretinitis along with retinal detachment. And when we did CSF on this cat, you could actually see the fungal spores present with that large halo around them. It also can't be given for longer than 12 weeks. So now switching gears to the feline viral infections. So just briefly, feline leukemia virus itself does not cause CNS disease, but because it'll suppress the immune system, they can get other CNS infections, or it can also predispose them to developing lymphoma and getting CNS signs that way. So if you have a cat who's FELV positive and they have signs, CNS signs, those could potentially be reasons. Now, FIV can actually cause an encephalitis, and it does this by causing perivascular cuffing, glial nodules as well. It is a neurotrophic virus, so it does like going to the nervous system. One of the most common signs of FIV encephalitis is going to be alterations in their sleep patterns. The CNS changes are very rare and naturally occurring cases, but cases that have experimental infections, about 25% of them will develop signs of the perivascular cuffing and CNS encephalitis. The other virus that most of us are familiar with is the feline panleukopenia virus, which causes cerebellar hypoplasia in utero. And it's from a perinatal infection or potentially vaccination of a pregnant queen with a live feline parvovirus. This should be non-progressive, so they're born with the symptoms, but then it should not get any worse as they age. I'll let you watch the video, but you can see the hypermetria and the head tremors present in this patient. These patients can have a good quality of life. They can get other CNS signs, although it is quite uncommon. If they are present, again, it should not progress. The next condition we'll talk about is feline ischemic encephalopathy. So this condition is thought to be associated with migration of acute-cerebral infection. It is the most common sign that you will see with it is going to be blindness, although depending on where the acute cerebra is migrating will depend on the clinical signs. So you can have seizures, aggression, ataxia, head tilt, but again, blindness is going to be the most common cause. The reason it's called feline ischemic encephalopathy is histologically the changes to the neurons themselves and the way that they actually die is consistent with what you would see with ischemic disease rather than other forms of necrosis or apoptosis, which is why it's given the name. But if you look at the slide on the left, you can see how it's very linear, as if though there was some sort of acute cerebra that had migrated through there. And then on the image on the right, you can see that there's areas of necrosis that can eventually form where that the acute cerebra has migrated. Some of the patients you can actually find the acute cerebra, as this is pointing to, but about half the time you can't. But because the changes are consistent with what you see with the acute cerebral migrations, it's all thought to be related, just at times the acute cerebra has exited from the calvarium and you can no longer find it. This is most common in August and the surrounding months as well. The signs are generally acute. If you had a patient where you're suspecting this, it's unlikely that you're going to greatly improve the clinical signs. Just like if you have a person that has a stroke, a lot of their signs aren't going to get much better. There can be some improvement, but it's not going to be drastic. You can give ivermectin, but also give some sort of steroid as well. And when you give ivermectin, you should pre-medicate with diphenhydramine. A couple more things to talk about. So cervical ventral flexion. This occurs in cats with some sort of myopathy or muscle weakness because they do not have a nuchal ligament. Technically, dogs don't have a nuchal ligament either because the nuchal ligament does not attach to the nuchal crest. However, cats have nothing that even resembles a nuchal ligament. So the most common cause is going to be hypokalemia. We'll finish up by talking about brain tumors in cats. So meningioma is going to be the most common brain tumor. It counts for about 40% of all brain tumors and about 60% of the primary brain tumors. The median duration of clinical signs until diagnosis in cats is about a month, which is crazy because when you MRI some of these cats, the meningioma can actually take up about 25 to 40% of the calvarium. And in order for a tumor to get to that size, it has to be extremely slow growing, so that way the body can compensate for it. And when you look at the median survival time of only being 18 days with medical therapy, that's because there's been so much compensation that's already occurred. There's not anything else that can really be done for these patients other than surgery. So medical management does not have a big benefit in these cats. As far as neurologic signs, behavior changes are going to be the most common. They can get ataxia and visual impairments along with seizures as well. But again, behavior changes, so unfortunately, somewhat unspecific signs. Your neurologic exam might help as far as localization because it usually will be lateralized. And it's usually within the forebrain as well. This is one of the surgeries to where removing a brain tumor actually does the patients a lot of good, and you don't have to follow up with any form of radiation therapy. So you can go from about a month, median survival time or less, without surgery to years with surgery. A lot of these cats died from unrelated causes from the meningioma. So it's usually older cats that get meningiomas. So they're going to have renal disease, hyperthyroidism. They can have their cardiac changes as well. But this is, again, one of the times to where surgery can be very beneficial for these patients. Lastly, we'll talk about lymphoma. So this is the most common neoplasia affecting the spinal cord and the second most common intracranial tumor. And it can present in a number of different ways. So the old saying of lymphoma can do whatever it wants is absolutely true here as well, to where it can be just a primary mass or it can be diffuse, what's known as lymphantomatous cerebri. You can even get just intravascular lymphoma, and you can get a meningitis or a choroiditis associated with lymphoma as well. It can be extradural, intradural. Again, name it, lymphoma can do it, unfortunately. Obviously, the clinical signs are going to be associated with where lymphoma is at. Now, similar to the dog, CNS lymphoma is usually part of a multicentric process. So the most common places that you can find it elsewhere is going to be the bone marrow and the kidney. So if you have a patient that you're suspecting lymphoma could be a possibility, doing an abdominal ultrasound, FNA of the kidneys and the liver, even the spleen or lymph nodes, can be quite helpful in these patients in diagnosing lymphoma. And the most common place that you'll find it is by doing a bone marrow as well. So if the owners don't want to do the MRI or want to do something prior to do the MRI, this is a case to where it would be completely reasonable to do so. I apologize that we had to do rounds this way, so if you have any questions, please definitely write them down and we could talk about them in the afternoon.